Thank you, Dr. Farid Garagazlu, our esteemed colleague, and I would say one-of-a-kind, amazing surgeon who make a big differences of our patient with hiatal hernia, especially giant hiatal hernia. So from a gastroenterologist perspective, hernia is I would say, a very simple thing, but it's not a very simple thing. The way we gastroenterologists perceive a hernia, or hiatal hernia, or giant hiatal hernia, is very different the way a esophagologist think about it. The way Dr. Garagazlu said, esophagologist, that means I'm a gastroenterologist with a special concentration on the esophagus. And when it comes to giant hiatal hernia, you heard that it's just not a simple hernia. And also you heard that the concept of lower esophageal sphincter is not really a sphincter, rather than a valve, rather than a functional gateway. And that's why it's very important to think about the anatomy, think about physiological perspective, and then help the surgeon for the treatment. Now, if I would like to talk about diagnosis and the workup of giant hiatal hernia, we have to know a little bit of anatomy, also the physiological function test. I would like to present a small case to you, which I very frequently see in our office. This is a 64-year-old Caucasian male presented with progressive dysphagia and cough. One of the important things about hiatal hernia, we always incidentally find giant hiatal hernia. We don't get a case that this is a hernia you need to diagnose. Maybe the patient went for a barium swallow or upper GI series, or just come just like this patient, progressive dysphagia, cough, and then we incidentally find it. So this gentleman has gastroesophageal reflux disease. That's why all we define for 30 years, hypertension and gout. No other significant medical history. But he has very interesting history. He has recurrent sinusitis. He has upper respiratory infection for last 3 years. His BMI is high, is 36. Obstructive sleep apnea, diagnosed 2 years ago. And this patient also has recurrent chest pain and has workup done in the hospital recently, and there's no acute cardiac problem was found. So this is a patient who presented to us with progressive dysphagia. Obviously, one of the first tests would like to see the anatomical problem in the esophagus. Obviously, we recommend an endoscopy. And here is a picture of this patient with endoscopy. You can see there is a giant hiatal hernia. And you can see the normal endoscopic view. You can also see the retroflex view. And when you look at this picture, you see here the phrenicocardiac angle. As a gastroenterologist, a lot of us was never really think about considering that. But when you work closely with a surgeon, when you look at the pathophysiology, when you look at the surgical history, which Dr. Garagazlu very eloquently discussed, how it comes to nascent fundoplication to today's surgery, why it is important. And you look at the barium study, and you can see phrenicocardiac angle and so-called gastroesophageal junction, and this big hernia is in the chest cavity. So obviously he was diagnosed with a giant hiatal hernia, and my responsibility is to talk today about diagnosis and workup. If I want to diagnose a hiatal hernia, when a hiatal hernia happens, what Dr. Garagazlu was telling, it doesn't happen in one day. Some people born with a hiatal hernia. But to develop a giant hiatal hernia, yes, some baby born with a huge hiatal hernia, but majority patient we see, it happens slowly. And it happens like a sliding hernia, which we traditionally said type 1 hernia, eventually go to type 2, type 3, and eventually type 4, which is a huge, humongous hiatal hernia. So if we talk a little bit about the anatomy, this is very important from a diagnosis point of view when you have a tubular esophagus, and we talk about typical A ring and the B ring. And B ring is basically nothing but a Z line, which you think about when you think about A ring to B ring, that's what the esophageal vestibule. And from the B ring, when you come to the diaphragm, right above the rugal fold, that is very important because that's why the phrenic ampulla is located right from the rugal fold to all the way to the A ring. And that's very important because this will define the function of the gastroesophageal junction or function of the valve we are talking about. And how much is displaced and what displaced with that will define this patient's mode of future surgery or what you're going to do with this patient. So if we think about the anatomy, we talk about type 1, type 2, and type 3. But what is important, if you look at the first picture, which is a normal esophagus and the stomach, you see phrenicoesophageal membrane is very important when it comes for the integrity of the esophagus, especially which is in the lower part of the thoracic cavity. It's important to think about this fascia, which is in the chest cavity, the fascia in the abdominal cavity. We need to think about the diaphragm. Why? Because whenever a type 1 sliding hernia happens, you see how disruption happens with a couple of things. Phrenicoesophageal membrane, which is disrupted. The fascia in the thoracic side as well as the abdominal side also disrupted. The nerve supply also get disrupted. And I give a very simple analogy. Just think about this. If this is the esophagus, and this is the lower esophageal junction, look, with every slice of the hernia, it goes up and down. And when it goes up and down, a lot of things happen. It affects the integrity of the muscle, integrity of the fascia, which is coming, also integrity of the nerves. And that's why not only the anatomy change, also the function of the esophagus changes. And that's why we see the failure of a lot of hiatal hernia surgery. And that's what you need to think, that just cutting the hernia is not enough. You really have to think about restructuring the esophagus and the stomach, basically correcting the anatomy. And that's what very important. And this concept is very, very important. This was very well studied in Oxford University. Why a sliding hernia when it becomes a giant hernia, what you really need to know. And this three-dimensional graph shows something very nicely. It shows the relationship between the hiatal hernia size, lower esophageal sphincter pressure, and the reflux score. As you can see, when there's no hernia, you have a good LES pressure. When the hernia size is barely 2 centimeters, you can see significant reduction of lower esophageal sphincter. As it grows bigger to a huge giant hernia, you can see it's not type 1 anymore, it's type 4, virtually have no LES pressure. And another important thing besides the LES pressure, this patient's reflux score can be significantly high, or patient lost the sensation of the reflux, and also with the distensibility of the esophagus, the patient developed dysphagia. Good number of patients develop dysphagia. And why they develop dysphagia? That's a very interesting question. And I go for the same analogy again. If I say that this is the esophagus, and if we just keep on pulling, imagine if we pull my coat 1,000 times a day, it will not be very effective anymore. And one of the most important things happen with the formation of the hernia. You have to think about the esophagus, because esophagus lose the distensibility. Esophagus, the nerve, almost shattered. So these patients develop very significant low motility or almost a peristaltic esophagus. And this is something you really have to consider when you do the workup for giant hiatal hernia, because you are going to face these things of dysphagia, not before the surgery, also after the surgery. And that's why what surgery you're going to choose is very important. The failure of the surgery obviously is not the preoperative or perioperative period, is 6 months, 1 year after the surgery. And we have seen from the big studies why Nissen fundoplication is not the best surgery. So another things I would like to talk about, the giant hiatal hernia, which is type 2, 3, and 4, paraesophageal hernia. It is associated with abnormal laxity of the gastrosplenic and gastrocolic ligament, which normally prevent the displacement of the stomach. And as the hernia enlarge, you see the greater curvature of the stomach roll up to the thorax. And because the stomach is fixed in the GE junction, the herniated stomach tends to rotate around its longitudinal axis, resulting an organoaxial volvulus. This is what I'm talking about, how a organoaxial volvulus is formed. And over the time, the entire stomach eventually herniates. And with the pylorus juxtaposed to the gastric cardia, forming an upside-down intrathoracic stomach. And this is the biggest challenge we are talking about. This is the biggest challenge because we have to correct these anatomical problems, what is happening. And that's what an important part of the diagnosis and the workup of the hiatal hernia. So this is a beautiful three-dimensional picture. When you compare, when I do an endoscopy of different kind of hiatal hernia patients in different stages, when I go in the stomach, one of the most important things is to do a very close lookup of the cardia, of the GE junction, look at the gastrocardia angle, which define is this patient is a simple type 1 versus type 2, 3, or 4. And you can see in type 1, where the normal ridge of the tissue approximate closely to the scope. But when you look at type 2, the ridge is slightly less well-defined. And when you look at type 3, the ridge is affected, and the hiatus is patulous. But when you think about a really giant hiatal hernia, the hiatus is wide open at all time. Initially, when I look at the respiration, I see this obliterate in the phases of respiration. Here, here, and here is usually always patulous. And that's important when you think about the pathophysiology of this giant hiatal hernia. So what is the key clinical feature? Because you understand that we don't really see a patient to diagnose a hiatal hernia. Most of the time, hiatal hernia is an incidental finding. And that's why they send to us. A good surgeon sent to us because they want much more information, not only the anatomy, but the functional perspective of the hiatal hernia. So endoscopic and radiological studies suggest 50 to 94% of the patient with reflux have a type 1 hiatal hernia as compared to 13 to 59% of normal patient. So good number of normal patient has type 1 hiatal hernia, and that eventually develop type 2, type 3, and type 4, eventually a huge sliding hernia or giant hiatal hernia. The likelihood of symptomatic reflux symptoms increases the size of the hiatal hernia. Maybe we're talking about type 2. And then when the patient with type 1 hernia have prolongation in acid clearance, especially with the recumbent position, that's the time we see the early physiological changes happening in the distal esophagus. And hiatal hernia compromise the fluid emptying from the distal esophagus by re-reflux from the hernia compartmenting during the swallowing. And that's why the patient developed the chest, lower chest tightness. And that's basically eventually predominant symptoms of our giant hiatal hernia patients. They don't have significant reflux symptoms because what happened, development of the hiatal hernia disrupt the nerve, disrupt the normal esophageal innervation, disrupt the normal musculature, and symptoms change to different type of symptoms. And I will talk about it. Our pulmonary colleagues, who will be talking today, Dr. Alabi, I see many patients from him who basically presented to him as pulmonary fibrosis, or who presented to him as recurrent upper respiratory infection as a consequence of this huge giant hiatal hernia. And patient does not have significant reflux symptoms, it's wide open, bile is traveling all the way to the esophagus, going to the airway, going to the sinuses, causing continuous problem. And those are the anatomical consideration as a pathway to developing of a giant hiatal hernia. Now, as I see, the most common symptoms, because we're talking about symptomatology, it's help us to diagnose it, is substernal pain or postprandial fullness, nausea, retching, and GERD symptoms is less prevalent as compared with the patient with type 1 diabetes, type 1 GERD patient or hiatal hernia patient. So this is important. Now, what are the most common complications we see with the giant hiatal hernia? And that's how the patient come to us. Gastric volvulus can cause dysphagia, while postprandial pain is usually related to gastric distension. Bleeding is not very uncommon, but occurs from gastric ulceration with continuous friction. We see erosions, which we call Cameron ulcer, and that is a definitive indication for the patient to go for surgical management. Also, rarely we see incarcerated hernia pouch. Now, respiratory complications, I just told you, upper respiratory problems, recurrent aspiration, recurrent pneumonia, pulmonary fibrosis, chronic sinusitis, these are also very common. So if we think about the typical and atypical presentation, as a clinician, you always have to think about, when you think about the diagnosis, they can have dysphagia, they can have dental erosions, they can have sinusitis, asthma, aspiration pneumonia, silent aspiration syndrome. I'm pretty sure our pulmonary colleagues see it very often. And those who are very smart, they always like to make sure this patient does not have significant functional issue of the esophagus or anatomical problem like a giant hiatal hernia. Pulmonary fibrosis, and rarely cardiac arrhythmia. Now, when you think about diagnosing, radiological findings are very important. And as I told you, most of the time, the primary care doctors or surgeons or pulmonologists or even allergy immunology doctor, they incidentally find this huge hernia. It can be done by just simple upright radiograph, sometimes computer tomography, sometimes MRI. And these are some of the pictures we see very often, like this one, where you can see the big hernia is staying right there. You can see it's pushing the heart, obviously push the lung cavity, reducing the effective space for the lung. And if you do a barium swallow, you can see that the upper GI series shows this big hiatal hernia. And when you do a CT scan, you can also see that. And see how notorious they are. They slowly push the heart, obviously push the lung, reduce the effective lung capacity. So when you are clinically suspicious about hiatal hernia, it's very important because patient come not necessarily a typical hiatal hernia symptoms. Obviously, reflux, heartburn, regurgitation, and dysphagia. Regurgitation and the dysphagia is the most common giant hiatal hernia symptoms. And that prompts us to do rapid workup, endoscopy, or other functional studies. And also, giant hiatal hernia is suspected in patients with a history of surgical dissection of the hiatus. Like the patient has anti-reflux procedure, or esophagomyotomy, or partial gastrectomy, and epigastric of substernal pain or fullness, nausea, or vomiting. And as I told you, the hiatal hernia not a diagnosis that is pursued in and of itself, and is usually diagnosed incidentally on upper endoscopy, manometry, or other imaging study. And I'm telling it again and again because most of the time the patient has not significant typical symptoms with giant hiatal hernia. They present completely differently than your typical reflux. So how we diagnose? So the patient we saw, the first thing we did is upper endoscopy. But sometimes we combine the upper endoscopy with the barium solo to look at the functional dynamics to give some more information to the surgeons. And in fact, surgeons do most upper GI series than us. We depend more on endoscopic evaluation, and we have a wonderful tool called manometric study with impedance. Is really replacing a lot of tests to give us much more information of the management or when we do the workup for the patient for giant hiatal hernia repair. So obviously, the endoscopically you can see, I just told you that this is a type 3 hiatal hernia. You look at the radiograph, you can see the part of the stomach is going to the chest cavity. The same picture again, you see the huge portion, and you can see also the change of the axis, advanced giant hiatal hernia. So what are you going to do when I do diagnose a big giant hiatal hernia? I definitely would like to do a high-resolution manometry. Because what we are talking about, the change of the dynamics, change of the function, we are talking about a valve. We are talking about a valve. We are talking about the change of the anatomy. You have to always think about it. It's just not simply fundoplication we're talking about. We have to think about the diaphragm. We have to think about the crura. We have to think about the membrane coming from two different perspectives, from the thorax as well as from the abdomen. You need to correct all those. And then also you have to think about what are the changes happen during the development of this giant hiatal hernia. It has to be a holistic approach. You just can't. It's just not blocks of bricks that you just fix it. You have to think about the anatomical changes happen over the time. You have to think about hyperalgesia. You have to think about the so-called leaky esophageal wall. You can think about the teared esophageal muscle. And that's why this high-resolution manometry is very important. And if we can combine the esophageal pressure topography with that, EPT, it is very important because it can tell us a lot about the crural diaphragm and the lower esophageal sphincter pressure. Unlike conventional manometry, when you combine the high-resolution manometry and EPT, it can reliably identify a sliding hiatal hernia as it permits real-time localization of the GE junction component without a typical swallow or distension-related artifact. And that is very common. That is very common when you do an upper GI series. So this is a picture of a typical ERM, where we analyze high-resolution manometry, but we also would like to see lower esophageal sphincter and crural-diaphragmatic matrix together. And when you do the test, when my technician do the test, it's very easy for us nowadays just to use a very, very special computer software technique to diagnose the HRM through the HRM LES CD matrix. And it really helps us to find out not only detecting the giant hiatal hernia, but also to predict how and what kind of surgery can be helpful to these patients. And that's why when I see a big hiatal hernia and combine this test, it tells us if these patients really get benefited from robotic valvoplasty or not. I never think about sending any giant hiatal hernia for Nissen fund implication because, as I was mentioning, that the pathophysiology of hiatal hernia, you have to think quite a bit of different component rather than just work on the fundus or cardia. So you have to have a total approach rather than a very simple approach. As Dr. Garagozlu was telling, that we have to think about the whole elephant. You just can't think about the one leg or one tail. You have to think about the whole thing. And this is what is very, very important. I do a HRM, and this is what I find out. This patient has esophageal aperistalsis because the chronic pulling and pushing the esophagus make these changes in the esophagus where the esophageal sphincter, yes, it is very tight, but the body of the whole esophagus, as you can see, there is no change of colors. It's like an ocean, blue ocean. It looks good, but it's not feel good. The patient has dysphagia because of that. Not the huge hiatal hernial sac causes a lot of anatomical and physiological issue, but the esophagus over the time doesn't work. And these are the patients you really have to think about it. This is a body's defense mechanism because you have this wide open hernia. So the esophagus kind of obstruct your food not to go right away to that. So that's the physiological analogy, not practical thing. But you have to think about this. And if this patient has esophageal aperistalsis and you do a robotic valvoplasty, you have to be ready that this patient will have significant dysphagia and have to think about the different kind of approach of surgery of these patients. And that's why a surgeon who don't know the anatomy very well, the size, the cruroddiaphragmatic angle, and also ERM study from a very experienced gastroenterologist, I think they commit a big mistake just to do a surgery to these patients. When it comes to treat a giant hiatal hernia, it's a team approach. It's a total team approach, and it's a very, I would say it's a very holistic approach when you combine an esophagologist who don't only just do an endoscopy and say it's a small hiatal hernia, it's a motor side hiatal hernia, rather than do a complete study and understand what are the physiological changes happening in this patient and think about post-operative perspective, what are the complications this patient is going to face. That is very, very important. And these patients who has giant hiatal hernia with esophageal aperistalsis, these patients likely have different sets of post-surgical implications, symptomatology, which we need to address before the patients go for the surgery. So after the surgery, the patient come and tell, doctor, you did my surgery, but I have new problems, and your surgery is a failure. And that's why it's very important to discuss pathophysiology, take longer time to discuss the patient, what is the implication of your surgery. And that's how important part of our diagnosis and workup. When we talk about diagnosis and workup for the surgery, workup for the post-surgical complication or physiological changes of the patients we need to talk about. And this is another area where you also ignore quite a bit. Delayed esophageal emptying as well as delayed gastric emptying with change of esophageal motility. We need to think about it. And yes, some surgeons do think about it. They do pre-surgical gastric emptying study to show the patient, look, your esophageal, your gastric motility is impaired. But you have to understand one big thing. With a giant hiatal hernia, disruption of your fascia, disruption of your muscle, disruption of your nerve, and also a majority of your stomach in the chest cavity, obviously they don't have the real functional motility of the stomach, and this patient has impaired gastric emptying study. You need to talk about it, that these things might not improve, or these things might improve slowly. Post-surgery, you will have significant, no significant symptoms of many things, and you might develop significant symptoms of gastric emptying. You have to counsel this patient because this is the physiological changes happening just normally in the process of developing hiatal hernia. And that kind of discussion need to be done before the surgery. is very important. And again, a good number of patients, they do improve their gastric motility because you are correcting the anatomy, and patient's stomach is getting big space now, functional space to work on the food. But again, some patient, it may not work. So it's very important to talk to them. And there's a very interesting study which is done by our colleagues in Germany, where they look at the gastric emptying study, as well as they look at the esophageal motility over the time of one simple swallow. And these are the things they see when it comes to a study where there's a solid phase of the food is getting easily going to the stomach, but over the time, even in the phase of first, second, and third swallow, look how ineffectively it is getting cleared. And that is an area which we don't know very well, don't think very well. And the same way, in the stomach also, the same thing happened, we don't understand very well. There's many things, many pathophysiology in the hiatal hernia, functional and physiological changes in the esophagus, in the crura, in the diaphragm, and in all this membrane. And the functional perspective, what we are talking about, we don't know much. As Dr. Garagozlu was telling, we need more work on these areas. And the way we envision just doing a surgery to fix it, it might not be that simple. It might be more than that. It might be role of entirely different thing. It might be role of the dynamics of the circulation of the blood vessels during the change of this hiatal hernia happen. It might be completely different than what we are thinking about. It might be a leaky lining of the esophagus causing a lot of symptoms. A lot of patients who are sent to me by the surgeon because they develop this chronic cough, they also feel burning sensation of their pharynx. They don't have sinusitis, they don't have respiratory problems, but they do have these upper respiratory pharyngeal symptoms. The ENT doctor do their study, I do my study, and I don't find anything. So we talked about hyperalgesia. We talked about a totally different perception of the nerves of different areas. It might be something with that. We might think about the modulation of the nerve rather than something else. And a lot of work needs to be done for that, and we're looking forward for that challenge. I think that's about the diagnosis and the workup for the giant hiatal hernia. I can tell you, we don't know probably a lot. We just know the tip of the iceberg. We have more to work. And once again, I would like to thank Dr. Garagozlu to invite me to come here and talk a little bit about the diagnosis and the workup.